Welcome to today's Explainer. Today, we are diving into a true, undeniable modern medical miracle. I'm talking about hemodialysis. It's an incredible procedure that literally saves millions of lives every single year by stepping in and doing the heavy lifting for failing organs. But, well, hidden right inside this life-saving process is a fascinating and honestly highly dangerous biological plot twist.
Here's our quick roadmap for today. We're going to hit 1. The hemodialysis solution, 2. Modalities and survival, 3. The danger of speed, 4. Dialysis disequilibrium syndrome, and finally, 5. Diagnosis and treatment.
Okay, I want you to keep a bit of a paradox in the back of your mind as we go through this today. Can a life-saving medical treatment actually be too efficient? Because, as we're about to see, rapidly clearing the human body of deadly toxins can, crazily enough, put a patient in really grave danger.
Let's start with Section 1, the hemodialysis solution.
So end-stage renal disease, or ESRD for short, represents severe kidney failure. We're talking about a glomerular filtration rate dropping below 15 milliliters per minute. Essentially, the body's natural kidneys are entirely offline. So hemodialysis has to step in and act as an artificial kidney. Blood gets pumped through a dialyzer, which is basically this high-tech semi-permeable membrane, to restore the balance of electrolytes and pull out waste and excess fluid. It does this through two main processes, diffusion and ultrafiltration.
Now, when does a doctor actually make the call to start up this machine? The indications for initiating dialysis are usually severe, life-threatening clinical signs. We're looking at things like an inability to control fluid volume overload or neurological signs of uremia. Uremia is basically this toxic buildup of waste that causes profound lethargy or cognitive impairment. Doctors are also looking for severe acid-base and electrolyte imbalances or even inflammation around the heart, which is known as pericarditis. When these red flags pop up, dialysis has to be started emergently or electively to save the patient's life.
To actually pull this off, you literally have to connect the human cardiovascular system to the machine. And we basically have two extremes for how to do it. The absolute preferred gold standard method is an arteriovenous fistula, or AVF. This is a surgically created connection that ideally needs to be placed 6 or more months before it's even used, just to allow it to fully mature. On the completely opposite end of the spectrum, we have tunneled central venous catheters. These are basically your emergency, last resort options because they carry a significantly higher risk of complications, like infection and thrombosis. So yeah, proper planning is absolutely everything here. Moving right along to Section 2, Modalities and Survival.
The standard, conventional in-center approach is typically 3 times a week for about 3 to 5 hours a session. We consider that our baseline. But check this out. An intensive regimen, say 5 to 7 times a week, often for over 5 hours a session, sometimes even done overnight right at home, massively drops mortality. The data shows a hazard ratio of about 0.53. In plain English, that means it cuts the patient's risk of death nearly in half compared to the conventional schedule.
That more frequent dialysis, like hitting it 6 times a week, drastically improves cardiovascular health across the board. It achieves way greater reductions in blood pressure and noticeably improves left ventricular mass. And if you think about it, it makes perfect physiological sense, right? By dialyzing more frequently, you are mimicking the constant, steady, 24/7 purification process of a natural, healthy kidney much more closely.
Which brings us to Section 3, the danger of speed. Okay, so we just established that efficient, frequent dialysis is incredibly beneficial. But what happens if you apply a highly efficient, super rapid cleaning process to a body that is severely toxic and hasn't been cleaned in a very long time? Well, this is exactly who is in the danger zone for our biological plot twist, dialysis disequilibrium syndrome, or DDS. The absolute highest risk is during a patient's very first hemodialysis treatment. Other major risk factors: having an extremely high blood urea nitrogen, specifically over 175 milligrams per deciliter, keeping in mind a normal level is usually under 20. Resuming dialysis after missing a bunch of sessions, or having extremes of age or pre-existing neurologic diseases also puts a patient at huge risk. The danger is highest when there is just a massive amount of toxin that gets cleared out all at once.
Let's walk through the actual physiology of why this happens, because it's super fascinating. It's called the reverse osmotic shift. Step 1, the hemodialysis machine is incredibly efficient. It rapidly clears small solutes like urea right out of the blood plasma. But Step 2, the urea inside the brain is trapped. It actually takes hours for the brain's urea to cross back over the blood-brain barrier and equilibrate. So, Step 3, this creates a really severe temporary osmotic gradient.
The brain effectively becomes a giant sponge, drawing water right out of the newly purified blood plasma and pulling it straight into the brain cells. And step 4, this water shift results in cerebral edema, which is brain swelling. The machine works so fast that it causes a literal, dangerous physical swelling inside the skull.
Let's look closer at section 4, dialysis disequilibrium syndrome. When a patient is sitting there in the dialysis chair, it usually kicks off with some mild early warning signs. During or maybe just shortly after the session, they might develop a headache, maybe some nausea and vomiting, blurred vision, or just general restlessness. Notice how incredibly nonspecific these symptoms are. They could so easily be dismissed as just, general fatigue from undergoing a major medical procedure. And that is exactly why this syndrome can be completely missed if the clinical team isn't hypervigilant.
Because listen, if that cerebral edema goes unchecked, the stakes escalate incredibly fast. Those mild symptoms can just snowball into severe, life-threatening neurological manifestations. The patient might experience profound somnolence, which is this intense, totally unnatural drowsiness, along with severe confusion. And that can quickly deteriorate into seizures, stupor, coma, and yes, even death. The swelling brain simply runs out of room inside the rigid skull.
Which takes us to section 5, diagnosis and treatment.
When it comes to diagnosing DDS, the absolutely crucial point to remember is that it's a clinical diagnosis of exclusion. There's no magical single blood test you can run for it. When a patient, especially a brand new one, starts showing these symptoms, doctors have to dive into an immediate initial evaluation. They've got to review all medications for sedating effects, check fingerstick glucose to rule out hypoglycemia, measure electrolytes, and assess for any hidden infections. They have to be 100% certain that it's the osmotic shift causing the issue and not a stroke or an accidental overdose causing the confusion. But here is the massive catch with treatment. You do not wait for that entire diagnostic evaluation to finish before you act. Empiric treatment has to start immediately, right in tandem with the diagnostic evaluation. If you even strongly suspect DDS, you have got to start treating that osmotic shift without a second of delay, even while you're still in the process of ruling out all those other alternative diagnoses.
So how exactly do we slam the brakes on that osmotic shift? Well, if the patient's symptoms are mild to moderate and they can safely just stay on the machine, the preferred treatment is called sodium modeling. This means quickly bumping up the sodium concentration in the dialysate bath. Adding sodium to the blood basically mitigates that osmotic pull that is sucking water into the brain. But if the symptoms are severe, we're talking seizures or coma, dialysis is stopped immediately, and doctors pivot to an emergency pharmacological fix. They will administer intravenous hypertonic saline, which is a super concentrated 23.4% sodium chloride, or they'll use mannitol to rapidly spike the serum osmolarity and aggressively pull that water back out of the brain cells.
Now, naturally, the very best treatment is just prevention. When initiating a brand new patient or maybe someone who has missed a ton of sessions, clinicians will purposely limit the efficiency of the machine. They intentionally dial back the speed. They'll use a much lower blood flow rate of just 150 to 250 milliliters per minute. They shorten that very first crucial session to just 2 hours. And then they will dialyze the patient on consecutive days to clear out the urea slowly and gently, completely sidestepping that deadly osmotic gradient altogether.
Which really brings us to our final takeaway for today. In the world of dialysis, slow and steady saves the brain. We started this explainer by asking if a life-saving treatment could possibly be too efficient, and the answer is a resounding, definitive yes. It is just a brilliant, wild paradox of modern medicine, and honestly, it leaves you wondering, as our medical interventions become increasingly powerful and ever more rapid, what other hidden biological plot twists are just waiting to be discovered when we push the human body to heal faster than nature ever intended. Thanks so much for joining me on this explainer. Keep questioning and keep learning.